So hello, this is Dennis Scanlon, Director of Penn State Center for Healthcare Policy Research, and I'm pleased today to be filming another episode of Ask the Experts. It's a series within our center where we talk with experts on particular areas important for health policy research. And today I'm very glad to have Dr. Danielle Downs, who is Professor of Kinesiology and Obstetrics and Gynecology at Penn State University, join me for this conversation. So Danielle, thanks for joining.
Thank you for having me.
So you have some fascinating work going on with respect to the opioid epidemic and how that really is having an impact in an area where some people might not predict that it would, and that is in the area of childbirth and child delivery. And so I want to talk about that today. But before we do that, I thought I'd like to give you an opportunity to talk about your research more generally. And as I understand it, you've done a lot of work looking at health behavior change, in particular populations of women at preconception, prenatal, and postpartum care. You've also done some work on obesity. So you're very, very broad in terms of your research interest, but maybe you could just describe that for our audience.
Sure, yes, thank you. So yes, my focus has largely been on identifying strategies to optimize behavior change during the transitional period for women, which in terms of the life course, the decision and the transition to have a baby and become pregnant is a huge life-changing factor. And thinking about behaviors such as managing appropriate weight gain, being physically active, and eating a healthy diet, things that all of us struggle with on a daily basis, become much more difficult to do during pregnancy because there's a lot of different factors at play, and mainly, moms and pregnant women are focused on the health of the baby. And oftentimes mom's health becomes sort of last on the list. And so we've focused our lab in my time here at Penn State over the last 15 or so years on identifying ways through intervention to promote management of healthy weight. Right now, we have a study we've just conducted in overweight and obese pregnant women and learned how to individualize the care, because overweight and obese women often have unique needs and barriers to some of these behaviors. So identifying ways to promote healthy eating, using mHealth tools to monitor one's weight, and making thinking about eating and cooking a little bit more fun and being creative, offering personalized exercise coaching and fitness instructors to help teach appropriate ways to exercise during pregnancy, which is often a fear of women of whether they can continue. And our work is largely focused around those three main issues of weight, intake, and expenditure, in a way that we can promote this before pregnancy, during pregnancy, and then thereafter.
Great. So we were talking earlier, and the connection to sort of opioids and the opioid epidemic, which I think most of our listeners certainly have heard of, and some may know more details of the challenge that this has created. In your focus on these populations, my understanding is, and I was interested to read this in your description of your project, hospitalization, the most common reason for hospitalization for a woman is for childbirth. Yes. And in the course of looking at what happens during delivery and type of delivery, you found that there is often opioid prescriptions, and that obviously creates a potential for addiction and a problem. So maybe describe how you sort of made that connection, and for our audience, what the real issue is here.
Yes, Penn State has spent a lot of time in the last couple of years emerging in terms of expertise and focus on the opioid epidemic, given the crisis at the national and at the state level. And through this issue and through our Social Science Research Institute and the emergence of the Penn State Consortium to Combat Substance Abuse, the CCSA, we have really started to look a little deeper about broadening interest in opioid use. I became personally interested in this space when thinking and talking with my colleagues, both on our projects as well as, folks that we work with in our clinical space, about overweight and obese women, and the fact that a large proportion of overweight and obese women will end up with a cesarean delivery. And when you start looking at the rates of cesarean section in the United States, and understanding that nearly 100%, or at least over 90% of women who have had a C-section will be prescribed an opioid after delivery. And when I started to understand that number, that striking number, in asking questions about what comes thereafter, I found that many of us were a little surprised that there weren't standard guidelines and recommendations in the immediate postpartum period for things like how long should they be on an opioid after delivery? Do they have it in the hospital? Do they take a prescription home with them? It's really difficult to find a lot of that data because it hasn't really been examined. So we did write a grant and received funding through our Penn State CTSI and SSRI to do just that, to really better understand in some larger practices within the state what the rate of prescribing opioids after delivery is, and then what are the characteristics associated with that. So do women go home with the prescription? How much do they need? How much do they take? And then really to try and connect that and understand if there is a connection to, say, at postpartum care. So 6 weeks postpartum or a year postpartum thereafter. There's very little data for us to understand what's going on during that space for usage and whether that becomes sort of a catalyst for further use if you've had more than one baby.
So a lot there that I want to ask about and fascinating. Maybe let's start with C-section rates more generally, because that's, I think, a problem in and of itself, as I understand it, and maybe you can help me understand better. In the population more generally of women giving birth, I think many believe that the C-section rate is much higher than it really should be. And maybe, I want to say, is it on the order of maybe 30% or so?
Yeah, so currently in the United States, about 1 in 3 deliveries occurs via C-section. So that's about 33%. And if you compare that to the literature, so over time, let me go backwards. So over time, this rate has skyrocketed in the United States. If you go back to about 1970, the C-section rate was roughly 5%. About 1995, it climbed to about 20%. And we're roughly in that 1 in 3 rate right now. So 33, 34%. When you look at the data that shows the importance of a C-section and the rates, over industrialized countries and underdeveloped countries, having the ability to perform C-section does improve maternal and fetal outcomes to a certain point. They call it a sort of a leveraging point at about 19%. So after about 19%, those rates of improved maternal and fetal outcomes plateau. So when we look at the United States and compare that sort of clinically significant number of 19%, we are way over that. In comparison, somewhere like Finland has roughly a 16% rate, which is really what we would think is more idealized place. Now, if I could then say that in the United States that this 33, 34% rate was associated with better overall outcomes, we would be happy. But unfortunately, recent data has really put the U.S. at the bottom of the list in industrialized nations for maternal mortality. So our maternal mortality rate has doubled while all other industrialized countries have declined over the last 25 years. So you have a emerging, increasing C-section rate in the United States, much higher than is really medically necessary. And you have also the increasing rate of maternal mortality. So these two things together are not the storm that we would like to see being, happening right now.
And then obviously, as you mentioned earlier, with those having C-sections, having a really high probability of getting an opioid, there's a risk for addiction. Correct. So again, one way to combat that is potentially to getting the C-section rate down to where it's clinically appropriate. That might be a first step, in addition to some other things. So Correct. Really interesting connections here that I think are important from a policy perspective. The C-section rate in women who are obese when prior to giving delivery, that's higher, I believe?
That's higher. The majority of overweight and obese women, even those attempting a vaginal delivery, will often end up needing to have C-section because there's often challenges with later stages of labor and delivery, and actually being able to facilitate full delivery, even if you're using any medicines or facilitators during birth. So, and then you have a situation where you have a woman who's then had a major surgery and then is recovering. And, even though many women in the United States elect to have C-sections, which is one of the reasons that our rates are so much higher, is that we do allow women to choose if they want to have a cesarean section. But there's other obvious reasons women, like an emergency C-section, that a woman might have, and overweight and obese women tend to have a higher rate of emergency C-sections as well.
Mm-hmm. Yeah, so maybe talk about that elective decision. I've always found that fascinating, but it's not in many ways different from our healthcare system generally. There's a lot of choice and decision-making that Americans want in their healthcare system. And certainly being involved in care choices is a good thing generally. But I think there are a number of examples, and I won't get into them, where actually having choice can create potentially problems here. So are there, what might be some of the reasons for actually allowing that choice when, again, there's risk with any surgical procedure, and maybe even additional risk when it comes to the medication and some of the other things that go along with it?
Sure. So, and that's absolutely right. There's a number of factors that come into play, particularly with C-section. If you think about elective C-section, one, everything that you just said, we allow women to have a say in that later stage if they're working with their OBGYN. And it depends on certain dates and times that those doctors are going to be in the hospital or delivering. Again, sizes of hospitals vary, and in smaller towns where you might have more limited maternity care, there are maybe surgeries that occur on Mondays and Fridays in town. And so women who might be afraid of a vaginal delivery, or might have some pre-existing conditions that elevate their chances of complications, so they're more apt to have a C-section, they elect to have that in a more controlled setting. So that was the original reason for a little bit of that flexibility. What I think has happened is there's other factors that are driving the increased rate in cesarean section as well. So you do have these issues of emerging issues of emergency C-section. So what might increase my rate of having an emergency C-section? Well, overweight, obesity complicates the pregnancy, complicates the process of labor and delivery. Many moms these days are older and having babies older, and that does also increase or relate to other comorbidities that can occur, problems with blood pressure, pre-existing or non-diagnosed preeclampsia that may become life-threatening during labor and delivery. So there's these factors that are pushing on one end that elevate this rate due to emergency C-section. Then there is elective C-section. Then we also have the issue of sort of defensive medicine, where a lot of providers are afraid of becoming sued. And if there is a complication during a delivery, and the provider had opted not to do an emergency C-section and there's an adverse outcome, often the worry is that I'm going to be sued because I didn't have this person have a C-section. So potentially something happened during a vaginal birth. So a lot of providers decide at a certain point in time during the progression of labor where their cutoff points are. And these cutoff points have varied over time. So it might be based on heart rate, so monitoring fetal heart rate. And at a certain point where the physician feels that baby might be in distress, we're not going to push any further, we're going to have an emergency C-section. It could be other factors, but some doctors, for example, will limit how long a woman is going to push during late stage of labor. And if they can't progress, they will stop and do a C-section. So these factors have all varied over time, but I think they've created a perfect storm of a combination between overweight and obesity, fear of delivery, fear of being sued. And so you can see why those rates have skyrocketed over the last 25 years.
Yeah. So we talked about the increase in C-section rates and sort of the gap between what people think is clinically appropriate in the rates that we have, in addition to just the potential risks for mothers and for children. There's also a financial aspect to this as well, isn't there?
Yeah, so for many people who understand from a healthcare cost, vaginal deliveries are generally thought to be less expensive than C-section deliveries because they're shorter period of time, less need for additional care and obviously surgery. But the costs across the board are skyrocketing for childbirth in this country. And when you look at the rates, which in the United States right now cost roughly between $9,000 and $17,000 to have a vaginal delivery. If you don't have health insurance and you have a baby in a hospital, that's the rough estimate. Now, if you have, depending on that insurance coverage, portion or the majority of that would be covered. But if you look at the rates of C-section, which are roughly from about $15,000 to $25,000, that's just for a normal C-section delivery. As we were talking about these rates of increase in C-section, there's also rates of increase in deliveries that are complicated that result in a C-section. And if you think about those, a complicated delivery could cost upwards of $25,000 to $50,000, and that's just for maternity care. So oftentimes when you have a complicated delivery, you also have complications with the infant, and so you have neonatal intensive care unit costs. And recently, the March of Dimes reported some of the numbers, financial numbers on this, showing that a 13-day stay in the NICU can cost around $75,000. And with the increase in our ability to deliver babies sooner, those NICU rates are also skyrocketing. So for babies born under 32 weeks gestation, the estimate is that cost can exceed $200,000 to $250,000 between the time that baby is born and discharged from the hospital. And so why do we talk about all this related to the opioid epidemic? Because we don't know the connections between some of the past factors like using an opioid during a first pregnancy and how that might be related to a complication in a subsequent pregnancy or in preterm birth or delivery. And so a lot of times these opioid addictions are undetected, particularly in this group of women, and emerge at a critical time, which is usually at labor and delivery when the problem is happening. So these ties with increasing costs, not only initially, but also in subsequent pregnancies, really need to be looked at further.
Yeah, no, very important. I mean, from the state Medicaid programs, expenditures and state budgets, quite significant expenditures, and we know that all state expenditures are being kind of questioned in kind of every area. But also with the advent of high deductible health plans, a lot of the first dollar coverage is being borne out of pocket by individuals, and it's not uncommon now to have some $5,000, $10,000 high deductible plans, which means that women and families are incurring a lot of these costs themselves for choosing one delivery mechanism versus the other. So
and oftentimes families aren't realizing that until after they're discharged from the hospital. And so it's a huge expense that used to be covered, generally in full.
Right.